Hello, and welcome to LAIVF Clinic's podcast series, Understanding Your Fertility, a podcast series specially curated to answer all your questions about fertility with fertility specialist Dr. Aykut Bayrak. And I am your host, Ara Behagan. Today, we are discussing male infertility. Now, this is such a broad topic that we broke this down into a two-part series. So today, in part one, we will discuss the common causes of how men could suffer from infertility and also how we test for it. Next week, we will discuss the treatment options for male infertility. And if you have any further questions or comments that you would like us to address in the future, please email us at info@laivfclinic.com. And thank you for listening. Hello, and thank you for joining my conversation today with Dr. Bayrak. Today we are talking about male infertility. I've been really wanting to talk about this because I hear so often that infertility is the woman's problem. And the myth out there is that men don't suffer from infertility. And I want to get to the bottom of this with you, Dr. Bayrak. Please set us all straight. Do men suffer from infertility?
Absolutely. Yes.
Okay.
That's a big yes. That's a big yes.
That's a big one. Okay, good to know. So can you help us then to define, how do we define male infertility?
So male infertility is related to anything that creates a situation where the semen parameters may be abnormal. So typically we diagnose it based on a semen analysis, or if there's something obvious in the history. Let's say somebody had some kind of surgical procedure when they were a newborn or in the first few years of life that we know that affected their potential to have a baby. Or if somebody was exposed to chemotherapy at a young age, radiation therapy, or they had some cancer in the testicular tissue and they had removal of the testicular tissue. So if some of those obvious issues are present in the history, then we absolutely know based on the history alone that this couple is suffering at least from male factor infertility. Short of that, if somebody just comes in and says, we're trying to have a baby and what are the issues that we might be having, the next step is automatically to do a semen analysis, which then will tell us whether there are abnormalities on the semen parameters, and which then would diagnose in a way that that couple has male factor infertility.
So can I stop you there? So
yeah.
when we test for the parameters, we're testing for speed, or how does that?
So we're testing for a bunch of different things, from the consistency of the sperm to the volume to the pH, the acidity. We're looking at whether there's an infection or not. We're looking at the amount of sperm. We're looking at the color. We're looking at the count, which is one of the most important things. Is there enough sperm being produced per ejaculate? We're looking at the motility, which is movement. Are the sperm moving around well? Are they swimming well? Are they moving forward? We also look at something called morphology, which is the appearance of the sperm. We want to see a certain percentage of the sperm looking normal. Sperm has three main parts: the head, the neck, and the tail. So under the microscope, we examine the sperm to see if the sperm looks good. And believe it or not, majority of the sperm look actually abnormal. And that's a normal finding.
Oh, interesting.
Yeah, isn't that interesting? So the production in the testicles is not perfect, far from it. And that's probably why men produce millions of sperm.
Yeah.
Just to find a few normal ones. So based on the current criteria set forth by the World Health Organization, or WHO in short, if somebody has about 5% of their sperm looking perfectly normal and 95% of their sperm not looking so great under the microscope, that's considered to be normal. So, I mean, this criteria changes over time. Every 5 to 10 years, they change the criteria. And the threshold has been going down and down and down over time because the sperm parameters have been going down for the last 50, 60 years. So men are producing less sperm. They're less modal, so they're moving around less. and they're looking more abnormal.
Mm.
So the criteria for normal sperm has really changed dramatically over the last 20, 30 years.
Wow. Wow. That's really interesting. So, can you walk us through? Because I think this is what gets a lot of men nervous too, as far as testing for a semen analysis. So, they'll have to come in to the office and produce, for example. So, can you walk us through what that looks like, just so that it's less scary and less intimidating for those who are listening?
Absolutely. So semen analysis is done through sperm collection,
Mm.
clearly. And ideally, we would like the men to rest and not have any intercourse, any sex, any ejaculation for about 2 to 3 days. Bare minimum is 2 days, ideally 3 days of kind of rest.
Okay.
But at the same time, we don't want them to wait too long. So we don't want them to wait more than 10 days. Most people use 7 days, but 10 days is reasonable. So about 3 to 10 days of abstinence is typically recommended in order to collect sperm and expect an accurate result based on the standards.
Okay.
So that's typically how it's collected. Sperm can be collected at home in a collection kit that we provide, and then brought in within a reasonable amount of time to the fertility clinic, which is then analyzed.
Okay.
Or it can be collected in the clinic. Most fertility clinics have a designated room. It's kind of private, and men collect it in a sterile cup, and it is then analyzed in the laboratory almost immediately, within a couple of hours.
Okay.
And then we know if there are any sperm abnormalities, and if there are, then there's a workup related to that. So the workup can be just repeating the semen analysis, because sometimes there are minor issues. That doesn't mean that that person needs an extensive workup. Whenever there's an abnormality, especially if it's minor, it's always a good idea to repeat the semen analysis in a few weeks. And majority of the time, it'll just come back normal, because men can be exposed to a lot of things which can affect sperm in that kind of time period. And if that exposure is gone in a few weeks or a month, then semen analysis can be completely normal, which then would eliminate an expensive and lengthy process of workup.
Right.
But if the abnormality is severe, meaning the count is just so low, there are a lot of abnormal forms, there's a lot of issues, or there's an infection, there are a lot of other things, then we obviously know that there is a problem, and that's not minor. So oftentimes then we do a workup or treatment immediately, because we know that the repeat is going to be almost always abnormal. And sometimes men have no sperm. So we do a semen analysis, and it's just liquid. It's just almost watery. So there's absolutely no sperm. And that in itself is a category that we'll talk about in the next few minutes. But that's kind of how you diagnose and understand whether there's an issue with men, or whether there's male infertility involved.
Okay, right. Okay, so I'm going to ask you a question. I hope I don't derail this conversation too much, but when you talk about if there's like maybe you do a second test for checking the sperm, so because you're worried, because you're thinking that maybe that first test there was some abnormality that happened during for that first test, so you just want to double check, right? So now I'm starting to think, like, guessing couples at home are trying to conceive on their own before they end up in a fertility clinic. So usually they time the ovulation and so on. So does the male partner need to beware of certain things during that ovulation period as well, when they're trying to have sex for 3 days straight? Does he need to make sure he stays away from heat, or what is it?
Yeah, I mean, in general, heat is not good for sperm.
Okay.
That's why sperm and testicles, they're outside the body, as opposed to the ovaries, which are inside the body, right? So certainly heat is not good for sperm. Too much heat is not good, and prolonged heat exposure is not good. Habits, smoking, excessive alcohol, certainly drug use, excessive weight, excessive stress, insomnia, any kind of medication use that can affect sperm parameters. Any kind of viral infection, including COVID,
Mm.
is a significant impact on sperm production. So
Mm.
I think just avoiding bad habits, leading a healthy lifestyle, keeping a balanced diet, exercising, minimizing heat around the testicular area
Mm.
are all things that men should pay attention to when they're trying to conceive.
Okay.
Around the time of ovulation, when the sperm is needed the most,
Yeah.
obviously, there's really no special activity that has to
Mm.
be done. There's no
Mhm.
special diet that has to be followed. As long as the men have a balanced diet,
Mm.
that's typically the issue. There are a lot of supplements that somebody can use. There are a lot of minerals. There are antioxidants that have been proposed over the years. There are a
Mhm.
number of studies that looked at these supplements, and some of them have shown improvements. Others have shown no improvement. So
Mm.
if there are issues with the diet, intake of vitamins, minerals, and antioxidants, then certainly supplementing those would be helpful, not just around the time of ovulation, but obviously
Mm.
leading up to that time so that the
Mhm.
buildup is there and the sperm quantity and quality are good. So that's definitely the case.
Okay, so how long does, because I was surprised to hear this, but please elaborate on how quickly can a man's sperm change? Like, does he have to have a good diet for 6 months, or does he have to have a good diet for a day? Like, what's the?
Yeah, I mean, 6 months is, I mean, certainly reasonable, and there's no doubt about that. One day is probably too short. So, sperm cycle is about approximately 60 to 80 days,
Oh, okay.
70 days, maybe
Hmm.
72 days or something
Interesting.
on average. So I would say probably at least 2 months if somebody
Okay.
wants to start with, good sperm from
Mhm.
scratch in
Okay.
a
Yeah.
way.
Uh huh.
So I would say 2 to 3 months would be definitely reasonable, but sooner you start, the better. There's no doubt about
Mhm.
that.
Okay.
So once again, improving lifestyle, as we always
Yeah.
talk about, diet, managing stress, and exercising, minimizing heat, taking supplements are all helpful.
Okay, that's good to know. Let's talk about then, you know, other than kind of the obvious, what are the causes of male infertility? Because I would guess, of course, my assumption is, but correct me if I'm wrong, but maybe smoking, like you said, drug use. But what other causes?
Yeah,
Um,
certainly. I mean, bad lifestyle, poor
yeah.
lifestyle,
Hmm.
certainly drug use, being overweight,
Okay.
obese, certainly that can affect testosterone levels,
Hmm.
which tend to be low, which affect the sperm quality. So all of those can affect things. The other obvious things that can affect are exposures to toxins, chemicals, certainly chemotherapy, radiation therapy. Those all will affect the sperm parameters. Sometimes genetic.
Oh. Hmm.
Men are born with certain genetic issues and they tend to have low sperm production. There's a condition called varicocele, which is
Mm.
a dilated blood vessel, a varicose vein, indeed, in the scrotum. Most
Mm.
people have them in their legs, typically
Mhm.
nurses, doctors, teachers, people who are standing for a prolonged period of time typically have varicose veins in their legs.
Mhm.
And men can have them in the scrotum, more
Huh.
commonly on the left side than the right side because of the anatomy.
Oh.
And these dilated blood vessels can increase the heat. They can create somewhat a kind of a backflow in a sense. And that can really create a toxic, hostile environment for the sperm. And that can be corrected surgically or through an embolization procedure where those blood vessels can be collapsed,
Oh.
just like varicose veins, basically. So
Mm.
that can be done, and which then will improve the sperm parameters. So there are treatments of such. The interesting part is that some men who are very fertile, may have multiple kids even, may have varicoceles. So varicocele is
Mm.
really not probably the cause, but rather kind of a coexisting issue that
Mm.
probably contributes to the problem
Right.
unless there's absolutely nothing else and the varicoceles are very large and dramatic, then certainly that can be the cause. But
Mhm.
most of the time, a lot of the fertile men actually have varicoceles and it doesn't affect their fertility. So
Okay.
certainly it's not the only cause, of male factor infertility.
Mm.
Other causes can be, certain traumas, for example. If there was trauma in childhood, men have tubes just like women, and these tubes carry the sperm from the testicular part to the epididymal part, which is kind of the storage facility for men.
Mm.
And then from there and through the prostate gland, the sperm comes out.
Mm-hmm.
So if these tubes are crushed or damaged, men can have obstruction. And that can be partial, that can be complete. And if it's complete, then no sperm will come out.
Mm.
If it's partial, some sperm will come out. Some of them will look kind of unhealthy or dead, or they may not be moving that well because they may get stuck in that obstruction.
Mm.
So those can be clearly causes or issues. And some men are born without those tubes.
Wow.
We call that absence of the vas deferens.
Huh.
We actually are treating a patient currently with that
Mm.
condition who had a biopsy from a testicular tissue because the sperm is just simply not coming out.
What do you mean? What a biopsy meaning? Just taking out the
Taking the
sperm?
sperm from a testicle because there's production, but the
Gotcha.
conduit is not there, so no
Mm.
sperm is coming out.
Right.
So that is another obvious cause
Mm.
of
Right.
male factor infertility. And the more severe form is something called azoospermia, meaning just absence of sperm in the ejaculate, which not only can be from the absence of these tubes that we just talked about,
Mhm.
but also it can be due to a production problem
Mm.
where the tubes are open, everything's working, but the main issue is in the testicular tissue, where sometimes there is early andropause, just like menopause,
Oh.
early
Oh.
andropause, where the testicles just shut down
Oh, interesting.
and they
Okay.
just don't produce any sperm. And in those cases, that's called
Mm.
azoospermia. And in also such cases, we do a biopsy from the testicular tissue.
Okay.
And that tissue is then examined.
Mhm.
And typically, about 30 to 40% of the time, sperm is found, even in
Really?
men who do not produce any sperm.
Wow.
Yeah.
So.
And that sperm can be used,
Hmm.
fertilized,
Mhm.
eggs can then be transferred, and that way the couple can have a child. So,
Well, that sounds kind of amazing that you can still find, even though they don't produce sperm, but that you can still find it.
right. So it's not that they don't produce; they don't
Okay.
ejaculate
Okay.
sperm.
Okay.
So they don't
Gotcha.
ejaculate. So nothing's
Yeah.
coming out because there's not enough
Mhm.
production. But there is
But they
some
are
production in the testicular tissue where you can actually go in and get that sperm. Now, success rates with such an approach are certainly much, much lower than ejaculated
Mm.
healthy sperm. There's absolutely no doubt about that.
Mm.
But it is certainly a treatment option where we can use that sperm still and get patients pregnant.
Gotcha. So how common is this? Because my other question is what it would seem like to me, because it takes an egg and a sperm to have a baby. It seems like it's a 50-50 issue. 50% the female, 50% male. But if the males just have less issues less often, is that the case, or can it easily be found or cured, not cured, but treated for male infertility? Is it just easier? Why this discrepancy is what I'm asking.
Yeah, I think in general, male infertility is easier
Mm.
because with IVF, in vitro fertilization, and the method called ICSI, intracytoplasmic sperm injection, which refers to picking up the best sperm one by one under the microscope with a microneedle
Mhm.
and injecting it into each egg. So on the male side, we have a little more of an advantage in the sense that we can pick up the better sperm just by looking at it. We can challenge the sperm. We can select the sperm through different processes
Mhm.
and use that better sperm to fertilize the eggs. Now, that doesn't necessarily mean that we're injecting a perfect sperm. There's
Mm.
absolutely no doubt about that. The sperm can still be genetically abnormal.
Mm.
Sperm can still be chromosomally abnormal,
Mhm.
even though it's looking fairly decent or normal under the microscope. But at least we can still find those sperm when we search under the microscope. So for that reason, even if there's a minor abnormality, there's still plenty of sperm to work with. That's what I'm trying to say.
Right, right.
In our clinic, majority of our patients have low egg reserve. So we see a lot of patients, probably about 80% of our patients in our clinic have some level of egg quality or egg reserve issues. So for our population here at LAIVF, it's a little skewed towards the female side, definitely. But there are a lot of cases where both female and male factors are involved. So it's just not the egg, certainly. And sperm can be an isolated issue where there's only a sperm problem. But oftentimes there is sperm in conjunction with an issue with the egg. So majority of the time it's both.
Okay.
In our clinic, it's probably a little more on the egg quality side, but that just might be because we're seeing a lot of patients who are referred to us for complex infertility. That can be an issue. And just our population is such that we see those patients where they may not have gotten pregnant with other treatment options that are kind of milder, or sometimes they're treated by their general OBGYNs and then they're not pregnant and eventually they come to us. So we probably see more difficult, complex kind of terminal cases in the sense where the egg quality and the reserve becomes more of an issue compared to sperm and male factor infertility. Now, that doesn't mean that we don't treat male factor infertility in conjunction with those cases. And oftentimes, there are some minor abnormalities, even in the best case scenario. Motility may be a little bit low. Morphology may be a little low, but those are still easily treated in the laboratory environment.
Okay.
Versus somebody with low egg reserve, it's a little more complex, needs a little more attention, and that's a little more challenging to treat, certainly.
So you talked about the egg, because we've talked before in subsequent podcasts that we can test the egg for, well, my question is, can we test the sperm for chromosomal abnormalities, or do we have to just create embryos and then test the embryo?
Yeah, so that's a good question. So as you know, our clinic, myself, I guess, back about 10, 12 years ago, we reported the first case of a genetic tested egg in California. That was the first time that we did, that we knew of at the time. So that was a unique case where the baby was born in 2010, if I remember correctly. It was a baby girl, healthy, and that was kind of a one-of-a-kind kind of a situation. Now, we don't do that as much as we did back then because, number one, it's an expensive type of a test. And if somebody has 20 eggs, you do it on all 20 eggs. So it's more of a cost issue. And that's why we're nowadays doing more end stage testing or testing the end product, if you will, which is the embryo. And we're testing the embryo at the final stage on the 5th and the 6th day, whereas in the past, we used to test them on the 3rd day. So a lot of things have shifted over the last 15 years. And so for that reason, we do less and less of that. But certainly, egg can be tested, and one can find out if that egg is actually chromosomally normal or not. Sperm, we can't do that because if you test that individual sperm, which technically can be done.
Really?
Yeah, I mean, you can take that sperm, single sperm, and amplify the DNA, but then you're damaging that sperm.
Okay, right.
You cannot use that sperm. So that's the problem with using individual sperm, where you just cannot test that individual sperm before utilizing that sperm and fertilizing the egg. So it's not possible to do that. Now, there are certain tests such as sperm DNA fragmentation testing that we offer in our laboratories. Actually, nowadays, we do offer that in our own laboratory, where we look at whether the sperm DNA has problems with it's getting fragmented when it's challenged in the laboratory environment. And if that is the case, then that can affect the fertilization capacity of that sperm. That can affect the health of that sperm. That can affect the overall genetic makeup of the embryo if and when that sperm is used to fertilize the egg. So the sperm can look beautiful under the microscope, but it can be genetically abnormal. That's still male factor infertility, if you ask me, right? So we do a lot of those tests these days just to better understand where there are these confusing cases of unexplained infertility, which I don't believe it exists. It's just that you have to look at the case much more carefully, and eventually you'll be able to explain it, right? So we're kind of a center that's known to do that. And when we do these tests in some men who have absolutely normal sperm, we find out that they actually have abnormal semen parameters. I just saw a patient like that a couple of days ago, actually, who had a fairly normal semen analysis, but he had a history of smoking. So that kind of pointed to a direction where everything else kind of looks okay on the surface. So I tested him.
And you did
with the DNA.
The fragmentation
Test, and it came back very high, very abnormal. So now we're treating him for that to improve the sperm, which then is going to improve eventually the embryo quality, so that we solve this kind of puzzle that went undiagnosed for a prolonged period of time.
So a typical test is, just to summarize, you look at history, you look at a semen analysis test from the production, and you can also test that production with the DNA fragmentation test. So there's kind of like three ways you look at this.
Absolutely, right. And there are other additional tests that we do, such as hormone testing. We can examine the patient and make sure they don't have a varicocele. Although oftentimes they don't. That's a urological exam. So if there are any suspicions, then our colleagues from the urology side examine the patients, and they do a whole workup in conjunction with our workup. In severe cases, we do genetic testing, chromosome testing of the patient, and then come up with a plan. So testing certainly can be as simple as an examination, making sure everything is good, including a semen analysis. Next level would be a much more in-depth examination by possibly a urologist, checking the sperm DNA, checking testosterone levels, doing detailed genetic testing, and then based on that, we come up with a plan. And the treatment options, I believe we're going to do that as another part, because that in itself is in a discussion.
It definitely is. And I'm excited to talk about what the treatment option would be. And we'll do that next time. So thank you as always, Dr. Byrak.
Thank you so much.
It's so informative. And to our listeners, please send us your questions. If you have any questions that you would like Dr. Byrak to answer on the podcast, please email info@laivfclinic.com and put the words "My Fertility Questions" in the subject line. And you can find out more about Dr. Byrak and LAIVF by visiting our website at www.laivfclinic.com, or follow us on Instagram and Facebook at LAIVF Clinic. And thank you for listening. Understanding Your Fertility is created by LAIVF. Please note that this podcast is intended for a broad understanding of the topics presented. It does not substitute for the medical advice or care of a physician-patient relationship. Podcast listeners should always consult with their healthcare provider regarding any medical condition that requires professional attention. Follow us on Facebook, Instagram, and Twitter. If the information on this podcast was useful for you, feel free to share it.